Good evening. I will present you today our concept of anatomical reconstruction of shoulder instability based on repair of soft tissue and bone lesions. In 1987, we published a classification of shoulder instability based on soft tissue pathology, mainly the Bankart lesion and capsule enlargement or redundancy, as well as bony lesions of the glenoid and the humeral head. The direction of instability was treated, the anterior, posterior, and the inferior, as well as the multi-directional. So the main three directions of instability which were in consideration at that time are these three, as I said before: anterior, posterior, and inferior. Nowadays, we have 8 definitions of instability, and each one has its own symptoms. We have now also the anterior superior, the superior instability, the superior posterior, the anterior inferior, and posterior inferior. By reviewing the literature, we found that approximately 90% of all cases of anterior instability have a redundancy and enlargement of the capsule, and an average of 30% of the cases have a Bankart lesion. So if we review the history of anterior shoulder instability, the open procedure started with a Bankart repair only, then also with tendon shifting or shortening of the subscapular with different techniques. Then in 1918, Neer has published this paper on the necessity of reconstruction of the capsule, and he presented the inferior capsule shift operation, added, of course, to the Bankart repair. The same thing, Carter-Rowe in 81 has also published his paper on Bankart repair plus medial shift of the capsule. Bony surgeries were also considered at that time. In 1939, Bristol, 44, Iliacris, autograph, and in 1954, Latarjet, as well as corrective osteotomy like Saha, Weber, and Meyer. The era of arthroscopic procedures started in 1980 with the Bankart repair, also with the stables by Lenny Johnson, then followed by suture transosseous fixation and anchors suture fixation, mostly widely used now, and also the overlap suture Bankart repair. Then capsular reconstruction was necessary as the failure rate was high. So there was the thermal capsulography and plication, as well as the arthroscopic overlap inferior capsular shift. Many cases are also treated with Latarjet procedure, as we showed before. So the open reconstruction of Neer, considering the anatomical reconstruction of soft tissue and bone lesion, was based on Bankart repair. The transosseous suture fixation was restoring the anterior glenoid concavity, while the ankle suture fixation did not restore the concavity, as also presented by Thomas and Matson in 89. Beside the Bankart repair, also inferior capsular shift was considered if we have an enlargement of the antero-inferior capsule. Here, the interval is closed and an inferior shift is done. Important after that is the immobilization of 3 to 6 weeks in order that the capsule will heal in anatomical zero rotation position. A modified technique then was published by Neer, addressing the unidirectional anterior instability. it is same as inferior capsular shift, but smaller incisions. For anterior glenoid defect, we used at that time the Bristow and latter J procedure and bone block procedures. For Hill-Sachs lesion, with more than 25%, bone block was used to fill the defects. A long-term results in recurrent anterior dislocation of the open inferior capsular shift was published with a mean follow-up of 28 years. This publication in 2022 have shown that the recurrence rate is only 3%, and that happens only 5 years after the surgery. 88.4% of the athletes return to sport at a level more than 70%. Now we come to our arthroscopic shoulder stabilization concept, which is based also on anatomic reconstruction. Before that, I review the procedures now. The Bankart repair is fix of anchors, as most of the surgeons do now. And if we have enlarged capsule, Bankart repair and plication is used. Now here in Egypt, the anchors have big problem in complications. We have a partial glenoid damage, as in this case. We have cyst formation and glenoid bone damage. Cyst formation and osteoarthritis can happen. Partial head damage and instability. Severe head damage. The untreated superior instability or anterior capsular redundancy can give us problems with impingement symptoms and anterior subluxation symptoms, as well as subluxation can lead to also loosening of the anchors. Inflammation and adhesions can happen. Disturbance of blood supply can lead to chondromalacia of the glenoid. Complication of glenohumeral arthritis of the glenohumeral joint. And complete destruction can happen even in young patients, which can lead to a total shoulder replacement. Now, our concept is the arthroscopic version of the open anatomical reconstruction concept. For the Bankart region, we also do the transosseous fixation as the open Bankart repair. Here we make from posterior a hole in the anterior rim, pass a PS wire or suture penetrating wire to pass the suture through the hole. And then we pull the suture through the anterior labrum, pull the two ends out, and then tie the labrum to the anterior glenoid. For this, we use the so-called chop needle puller. It's a very important instrument, as we will see. Now, for enlarged capsule, we have the translation of the inferior capsular shift. We call it the overlap inferior capsular shift, arthroscopic overlap inferior capsular shift. We cut the lower half of the capsule in L shape, and then we pull the lower half over the upper half and tie it together. Of course, this is added to a Bankart repair if present. With this, we get a good centralization of the head in the glenoid and a stronger capillary through overlapping. And also, we can close the interval if it is open. Here's a video showing the technique. We make a transverse cut, then longitudinal cut near the neck. We pass the chop needle catcher with the suture through the skin and pull it also with the puller through the skin. Then we pull the two sutures and we tie the lower flap on the lateral end of the upper border of the subscapularis. Also important is post-operative immobilization in neutral position. We call it anatomical sizing of the capsule. This is, of course, 3 to 6 weeks, depending on the quality of the capsule. Now, if we have a bony Bankart or an anterior glenoid fracture, we also use the overlap Bankart repair and compress the fragment to the glenoid. Rarely, when there is a defect and loss of bone of the anterior glenoid rim, we use a bone block and arthroscopic placement of the bone block anteriorly, and then fixing it with suture using a suture passer wire like that of the ACL wire. Now, Hill-Sachs lesion also, if the lesion is more than 15% or 10 to 15%, affecting the motion of the joint, we put a block, a bone block in the defect and fix it also with sutures with the mattress foam. Here, actually, the technique is by placing two sutures and making a big knot in the suture, pulling anteriorly, and then having a mattress fixation. The same thing is done if we have a reverse Hill-Sachs lesion. We put a block in the defect, a bone block in the defect, and pass the suture passer through the block and fix that in a mattress form. We see here on the right, the upper ends of the sutures are made like a knot. The end is like a big suture knot so that it does not pass through the block, and the bone block, and we can fix it to the defect. Like here, we have the mattress fixation, and we see the sutures. So another problem is the superior instability, which causes impingement syndrome. We call that the spoon lesion. It is a redundancy of the capsule without tear. Of course, super instability can happen also with partial tear of the tendon. And this has to be repaired to have a superior stabilization. And this is done by cutting the insertion of the supraspinatus tendon, pulling it laterally and fixing the transossary again to the greater tuberosity with a giant needle under tension, and thus having a superior stabilization. Now, in case of greater tuberosity fracture, which is displayed superiorly, we pull it down, fix it with K-wires, and pass the giant needle and fix the fragment with the transosseous suture knot fixation. If the fragment is displaced posteriorly, we pull it anteriorly to its place, and then we do a fixation using a suture passer from anterior to posterior and tying the fragment in its place. I will review now our last study on high professional athletes. 88 cases were able to review them. Most of them were handball players. All of these cases were done in Egypt. Then followed by weightlifters, soccer players, water polo, and others. The pathology found in these cases was hyperlaxity or redundancy in 95% of the cases. Bankart lesion in 32%, this is with enlargement of the capsule. And Bankart lesion alone without capsular enlargement, which happens mostly in first-time dislocation in 5% of the cases. Bony Bankart in 3%, Hill-Sachs lesion less than 15% in 5%, and spoon lesion, which is the cause of superior instability or anterosuperior, was present in 11% of the cases. Now, the treatment done was anatomical reconstruction of the pathology. So for the capsule, we did a cruciate inferior or overlap inferior capsular shift in 95% of the cases, Bankart repair in 33% of the cases, superior capsule tendon repair or tendon reefing in 11%, and Hill-Sachs bone graft in 3% of the cases. So the late results, with an average follow-up of 10 years, between 6 and 12 years, showed 95% of good to excellent results according to the ASES score. 1% also only traumatically dislocation, compared to 9.3% in the literature. While return to normal function, which is very, very important, instability is not only fixation and preventing of redislocation, but it is regaining of the function so that the patient or the athlete can live his life normally. This regaining of the normal function was present in 98% of the cases, while in the literature, only 55%. This literature was chosen for cases of Bankart repair only. In 97% of the patients, they were able to go back to their competitive sport level, and all patients could do overhead throwing activities. These are some of the athletes who have been able to win world championships and continental championships after dislocation treated with anatomical reconstruction concept. So in conclusion, finally, the concept of arthroscopic reconstruction of the anatomy in high performance athletes, of course, in also all comers with anterior shoulder instability, has proven to be highly effective in giving the athletes the possibility to return to pre-injury competitive level in more than 95% of the cases. Thank you very much, and I would like to invite you in 5 years and 7 months to attend the International Shoulder and Elbow Conference in Cairo in 2029. Thank you.